Good morning, everybody. Thanks for coming to Grand Rounds this morning. I'm Bill Gershon. I'm the Division Director for Pulmonary. And today's speaker is Terri Laguna. Terri is an assistant professor in pediatrics and actually is the longest tenure of any faculty member in pulmonary right now, which I thought is kind of interesting.
That made me feel really old, Bill. Thank you.
Terri also has some positions in the department. She is the director of the Pediatric CF program and is also the co-director for the CF Center at the University of Minnesota. Some of you may have noticed that Peds Pulmonary is listed on the U.S. News Survey. There are some billboards around the hospital. And I think one of the main reasons for that has been Terri's incredible care of our CF patients and her directorship of the CF Center. So hats off to Terri for that. Terri also does quite a bit of research, and today's talk will involve CF. And the title of today's talk is Towards a Cure for CF, Are We There Yet? So please welcome Dr. Laguna.
Thanks, Bill, and thank you to everybody for being here. I appreciate all the support, and thanks to all the people from my division and my team that came out here to support me as well. So my goal is to spend the next 45 minutes just kind of summarizing what my world is. Talking about cystic fibrosis and a lot of the advancements that have come over the past number of years. These are my disclosures. It's mostly grant support, none of which is relevant to the things that I'm going to talk about today. So the last time I did Grand Rounds was about 7 years ago, and this was my title. So I kept the same title. At the time, it was Towards a Cure for CF, Are We There Yet? And at that point, the answer was no. There were a lot of promising drugs in clinical trials, but we were not close to understanding or being able to treat the actual disease or the underlying defect that causes CF. However, 7 years later, I kept the same title, and I probably would venture to say not yet, but we're definitely getting closer. So ask me in 7 years, and there may be a definite yes. And then I'll still be the longest tenured faculty here in pulmonary. Oh, that makes me feel really old. Okay, so 4 objectives today. So I'll briefly review CF for those people that don't do this every day, just to kind of get you up to speed on what CF is. I'll describe a little bit about the pathophysiology of lung disease because that's the biggest cause of morbidity and mortality. I'll review 2 new and exciting therapies that are now approved for use in CF and talk about the direction that things are going. And then I'll review the outcomes of the Minnesota CF Center. So just to kind of let you know who we are and what we do and how we compare to other places around the country. So we'll start briefly by reviewing CF. And I thought I would review it in the context of 2 cases. One of which is probably about 12 years old. I presented this case at a CF conference back in 2004. So this is a 2.5-year-old boy with failure to thrive and recurrent pneumonia. He was born full term in Washington State. His birth weight was 7 pounds, 9 ounces. Clinical history was significant for frequent emesis, intermittent diarrhea, and foul-smelling stool. Failure to thrive with both height and weight consistently below the 3rd percentile. He had his first pneumonia at 7 months and then had 4 subsequent chest infections after that. And he had a chronic cough. His developmental history was significant for him being non-ambulatory, so not walking at 2.5 years of age. Unintelligible speech. He would babble, but you couldn't understand his words. He had very poor muscle tone and very poor coordination. And his family history was significant for a maternal cousin that had cystic fibrosis. So on exam, his growth, his weight and his height were both well below the 3rd percentile, and they'd always been there. His OFC, his head circumference, was preserved. So his head was between the 50th and 75th percentile. His vital signs showed he was tachypnic, and he was hypoxemic with an oxygen saturation of 87% on room air. And on exam, he looked very malnourished. He had tachypnea and retractions at rest. He had very poor aeration and diffuse crackles in his lungs throughout. His belly was distended, and his liver was palpable well below the right costal margin. He had clubbing, and he had no deep tendon reflexes and very poor muscle tone. So significant laboratory results on his evaluation. So he was anemic. His hemoglobin and hematocrit were low. He had abnormal coagulation studies with a prolonged PT, a prolonged PTT, and an elevated INR. His vitamin levels were all pretty much undetectable. So his vitamin A was less than 5, his vitamin D was 10, and in Washington State, that's probably what most people's is, but his vitamin E was also undetectable. So all of his fat-soluble vitamins were really undetectable. And his protein levels were relatively normal. So his sweat test, because he had not yet been diagnosed, was done at this clinic visit, and it was positive. So his chloride concentration was 107 millimoles per liter. That is floridly positive. Greater than 30 is considered abnormal. On skeletal evaluation, he had generalized osteopenia and severe demineralization. He had a bronchoscopy that was performed, and in his lavage fluid, so in the washing we did of his lungs, he had 67% neutrophils, which is a lot of inflammation. You shouldn't really have any neutrophils down in your airway at 2.5 years of age. And his culture from his lower airways grew Pseudomonas aeruginosa, the mucoid version. So this is the nasty version of Pseudomonas that you typically get more associated with older patients as they develop more end-stage lung disease. And his CFTR genotype, so the genetic mutations that cause CF, showed 2 copies of the most common mutation, delta F508, delta F508. So this is CF. So we did a CT scan on him. I'll use this. So the finding in CF, and I'll talk a little bit more about this in a few minutes, is called bronchiectasis. And bronchiectasis is when your airways get dilated. This is the right lung, and this is the left lung. At his age, this white chunk right here that's full of holes is a severely damaged and bronchiectatic portion of your lung. That will probably never be repaired or heal. And again, this is a kid that's 2.5 years of age. He also had extensive bronchiectasis throughout his right lung. So not just in his right upper lobe, it was throughout his right lung. So this is really him. I had permission from his parents to post his picture. So this is a symptomatic CF diagnosis. And prior to newborn screening, this is how we would diagnose CF. They would show up to clinic with recurrent pneumonias, failure to thrive, and all kinds of complications of CF. Malnutrition and malabsorption lead to poor growth. Fat-soluble vitamin deficiencies lead to the delayed motor skills and developmental delay. And advanced lung disease, probably because of poor nutrition and no care in terms of his lungs, result in early Pseudomonas aeruginosa infection, bronchiectasis that may never heal, and an oxygen requirement. So at 2.5 years of age, this kid is starting off well behind the 8 ball in terms of a diagnosis of CF. So he's an example. This case was before 2006, which is when Washington State started their newborn screen for CF. But countrywide and worldwide, this is how it used to be. We would get these kids when they already were symptomatic and had a significant number of problems. So you can imagine the road that lies ahead for a kid like this. The second case I'm going to talk about is a 12-month-old boy, so 1 year of age, who presented here to our pediatric CF clinic, and some of my team is going to recognize who this patient is, with a known diagnosis of CF. So he had been diagnosed by newborn screen. He knew, and his family knew, he was delta F508, delta F508, so he had CF and he had a positive sweat test. He was diagnosed by the Minnesota State newborn screen, and he was seen by the Mayo Clinic CF program at about a month of age, which is pretty typical for when we will see these patients. However, the family did not return to the Mayo CF program, nor did they go to any other CF program in our state or any surrounding state. Instead, they were followed by a primary care physician in Decorah, Iowa. Enzymes were prescribed, and I use the word prescribed loosely because they were not being prescribed or overseen or supervised anybody that really had much experience in cystic fibrosis. So there was no registered dietitian with pediatric CF experience. There was no physician who really knew how to take care of CF. So he had enzymes that were not being used correctly, and he was supposed to be having bi-monthly weight checks. This was an Amish family, which presented a whole number of issues in terms of this child getting care, although there was another child with CF in the family. When he presented to our clinic, his weight and height weren't even close to the growth chart. And his weight for length, again, wasn't even close to the growth chart. His exam was very similar to the one I've just described. So he was thin, small, malnourished appearing. He had this pretty bad nasal congestion, retractions at rest, very distended belly. You could see all of his ribs. He really had no subcutaneous fat. He was hypotonic, he was unable to crawl, and he had a lot of difficulty sitting on his own. He was also an unimmunized child as well. So same thing in terms of his laboratory results. So he also was anemic with a hemoglobin of 9.8. His vitamin levels were also undetectable on the fat-soluble vitamins. A, D, E was on the low end of normal, and K. And his albumin was also a little bit low. So although the diagnosis was made by newborn screening, without appropriate treatment and follow-up, the same complications arise. So malnutrition, malabsorption, vitamin deficiencies, neurological impairment, developmental delay, lung disease. The hope is that these can be treated and severe complications can be avoided by newborn screening, early diagnosis, and early and appropriate treatments and care. So any guesses, besides my team, as to when this patient was seen? $5 years ago. No, not 5 years ago. Yes, Kathy? Last year is correct. We saw them in the fall of, actually November of 2016. So this was as recent as a few months ago. Okay, so cystic fibrosis, the most common autosomal recessive lethal genetic disease in a Caucasian population. So it's caused by a genetic mutation in chromosome 7, which codes for a chloride channel. And I'll talk a little bit more about what that means and how that translates into disease. So you need 2 copies of the bad gene in order to get CF. So one from the mother, one from the father. And a lot of times parents don't even know that they're carriers. They have to have at least 1 copy of the CFTR gene. You have no symptoms if you're a carrier. So you would never know unless you're tested as to whether you actually carry a copy of a CFTR mutation. So anytime 2 parents that are carriers come together, they have a 25% chance of having a child with CF. And that's independent. So every time they have a child, it's 25% chance. Every state in the United States now screens for CF. Each state started differently. So if you guys go out and practice anywhere outside of the state of Minnesota, we started in 2006. It's important to know where you practice, where your state started screening, because that kind of helps you decide if you're seeing an older kid who might not have been screened, CF should be higher on your list. So although when you hear CF, most people immediately go to the lung disease, the reality is CF can affect almost every organ in the body. The way that I explain it to patients and parents is that any place or any organ in your body that makes, releases, or secretes something is going to be affected, because the chloride channel that is defective is responsible for salt and water balance. So you're talking about the lungs, the sinuses, sweat glands, pancreas, intestines, liver, gallbladder, male and female reproductive systems. All of those organ systems are affected. What we see in clinic kind of just demonstrates and illustrates the importance of a multidisciplinary team of people that are experts in all of these areas. So not only do we see lung disease, it's sinus disease, dehydration, malabsorption, malnutrition, vitamin deficiencies, diabetes, cirrhosis, all kinds of things, and a lot of the complications that both of the kids that I presented earlier have. So these are the things that we deal with in clinic in our CF patients. So I'm going to spend a couple minutes talking about the pathophysiology of CF lung disease, because that's the biggest cause of morbidity and mortality in CF. So the lung disease actually begins early. So you saw in an untreated, undiagnosed 2.5-year-old all the sequelae of lung disease that can happen. So it's characterized by the progressive loss of lung function, and also infection with pretty predictable what we call CF pathogens occurs over time. So Staphylococcus aureus, Haemophilus influenza, Pseudomonas, Burkholderia, and Achromobacter. I can only say those because I've said them over and over again. Pretty predictably infect the lungs of these patients. And unfortunately, for as good as we've gotten in the care of these patients, respiratory failure is still the primary cause of death in the majority of patients that have CF. So we can have the lights come down a little bit. So I wanted to kind of show you, just in visual kind of movie form, what CF does, how CF is caused by a chloride channel dysfunction in the lungs. So we're going to watch a very short 20, 30-second video that basically will show you an epithelial cell in the lung with cilia moving back and forth and a mucus layer that's sitting right on top of the cilia. So this first video is normal. So this is how mucus clearance, the mucociliary clearance should happen within the lung. So this is an epithelial cell in the lung that does not have cystic fibrosis. So here are your cilia moving back and forth. The mucus layer is the green layer that's moving on top. And this is how it should be. The cilia are moving, mucus is moving. There is your epithelial cell. That's how it should look. Now we're going to drill down right into that epithelial cell surface, and you're going to actually see the chloride channel and how ions pass very easily through an open functional chloride channel. So here's your chloride channel. It should be sitting right in the membrane. Chloride ions can come through, and back here are sodium channels. So chloride, salt, and water all work to keep the mucus layer thin and moving in the lungs. And this is how it should be. So this is the same video, but now this is an epithelial cell that actually has CF. So it's the same view, cilia moving back and forth, mucus layer on top, except now the mucus is so thick that it just sits on top of the epithelial cell layer. The cilia are fine. They're functionally okay. They just can't move because it's like trying to move concrete. And if now you go back and look at that epithelial cell surface, now these chloride channels don't work. So there is no chloride transport able to move throughout the membrane. As a result, sodium, I don't know if you can see it back here, is pouring in. Water is following that. So the mucus is completely dehydrated and like cement sitting in the airways. And that's what really is responsible for a lot of the issues that we have when it comes to lung disease and CF. So to kind of walk you through things, so it starts off with chloride channel, thank you, chloride channel dysfunction. So you have a chloride channel that doesn't work. That affects your salt and water transports. It impairs your mucociliary clearance, which causes mucus obstruction, that green layer just sitting on top of the lungs. If you can't move mucus, you can't clear infections or bacteria out of your lung. We constantly inhale, Lord knows what, down in our lungs all the time. We don't think about it because our mucus is thin. Our mucociliary elevator works, for the most part. And you clean and basically get rid of all the pathogens and microbes from your lungs. So it keeps things pretty healthy. But if you can't move it, bacteria, fungus, atypical mycobacteria, all those things just stick and stay down in your lungs. So that results in infection and inflammation. And that cycle is what causes damage to your lung, decline in lung function, and ultimately respiratory failure. So that's how you get from a dysfunctional chloride channel, unfortunately, to death in somebody with CF. So I wanted to show you a couple pictures. So this is CF lung disease, what it looks like on a chest x-ray. So this side is the normal side. So the lungs should normally be black. Solid things, your organs, your muscles, your bones are white. So your heart should be here in the center of your chest with your spine, right lung, and left lung. And both lungs should be very black on both sides. This is an example of end-stage lung disease with CF, where you have that white haziness and almost a cystic appearance in the lungs. On CT scan, you get a much better view of exactly what the damage is. So the finding on CT scan, and the major finding in CF lung disease, is something called bronchiectasis. And what bronchiectasis is when an airway dilates. So this is an airway disease. So the video that I showed you was in the CF airway. Bronchiectasis is when the blood vessel and the airway, so this is normal, so the ring on this side should be the same size or smaller as the adjacent blood vessel. That's normal. If the ring is now bigger than the adjacent blood vessel, that is abnormal, and that's bronchiectasis. So all of these holes, it looks very much like Swiss cheese, all of these holes are abnormal. That's damage. That is bronchiectasis, and again, a lot of that is likely irreversible once it happens. And then finally, for all the scientists out there, under the microscope. So again, this is an airway disease. So here is an airway lined with smooth muscle, epithelial cells, and nothing in the lumen. So this should be very easy to breathe through an open tube. These, take my word for it, are the alveoli around the air tube, and these are completely normal. So again, this is not an alveolar disease. This is an airway tube disease. CF, here's your airway, and now your air tube is full of white blood cells, bacteria, debris. You can't breathe through that. That's the main finding in terms of what you see under a microscope. Again, these alveoli are normal. So at the end stage, you can get some involvement of the airways, but for the most part, this is a disease that happens in the air tubes. So each year, as we have gotten more experience, more research, more knowledge, we have done much better in taking care of our patients with CF. So this graph starts in 1986 and goes up to the most recent data we have, which is 2015. On the left, or on the y-axis, is the median predicted survival age in years. So back in 1986, we were about 29 years of age. And now, up until 2015, we're close to 42. So for the most part, each year, there's been steady improvement in terms of the life expectancy of somebody with CF. The humbling part about this is that a lot of us in this room wouldn't be here if we had CF. So 42 is better, but it's not okay. These people still have very shortened lives. And the end part of their life is brutal. This is not a fun disease to live with. So we still have a very long way to go in terms of taking care of this patient population. So although our life expectancy numbers are climbing, our lung function continues to decline. So what this graph shows you is age in years along the x-axis, and FEV1 % predicted, so lung function, the measure of obstruction, on the Y. These are different cohorts of patients born in 1986, 91, 96, 2001, and 2006. What this shows you that if you are 6, and that's the first year you can do a lung function test. Back, if you were born in 1986, the first time you could do a lung function test, your FEV1 was about 88% predicted. Nowadays, you're pretty darn close to 100. So you are healthier at 6 than you were 20 years ago. However, after a few years, around 9 or 10, you start to decline, and the slopes of those lines are almost identical. So although kids are healthier, the rate of decline of lung function has not changed. We have not been able to do anything that has impacted the decline of lung function once it starts. So that's the challenge we face, is how do we do that? And again, for those of you that don't know, one of the main measures of what we follow in our kids and adults with CF is something called the FEV1, and that's done by doing a pulmonary function test. So again, for the pediatricians that are in the audience that are going to go do general practice, it's important that if you're dealing with kids, that you have a respiratory therapist. Amy Nelson's sitting here. This is Amy Nelson, our pediatric respiratory therapist. What? Move off the slide? You can't even see you. You're getting ready to take a deep breath, right? Yeah. You need to have a respiratory therapist that knows how to work with kids. You need to have software that encourages kids to blow out long, hard, and fast. So this child is going to blow out birthday candles on a birthday cake. So this is an incentive to get a kid to be able to blow out. And you have to be able to do that to get a good pulmonary function test. Kids would much rather blow out birthday candles, blow balloons across a stage, blow a house down, all kinds of things, gets them to actually do the test. So if you guys ever order PFTs in clinical practice, make sure you refer to a place that knows how to deal with children, because that's important. Okay, so now I'm going to talk a little bit about 2 very cool treatments that we now have available that we did not have available 7 years ago for use in CF. Up until about 5 years ago, our approach to CF care had been largely reactive. So CF was always one step ahead of us. The chloride channel was the problem, and we had to treat the complications of that. So it was pancreatic insufficiency. We give vitamins, we give salt, we give pancreatic enzymes. We treat that. We give extra calories, we put in G-tubes. We do what we need to do to treat that piece. For the mucus obstruction, we treated that. So kids and adults inhale mucus-busting medications. They take inhalers. They do airway clearance. They put on that vest that shakes to physically move mucus. You do what you can to try to relieve that mucus obstruction and break up that mucus and make it watery and easier to cough out. Airway infections. I rattled off the number of bacteria these kids get. So a lot of the mainstay of treatment is antibiotics, oral antibiotics, IV antibiotics, inhaled antibiotics. If we could have them bathe in antibiotics, we probably would. They bathe in Mucomist for the most part. But that's the mainstay of treatments. Like, we are always one step behind the disease. Until now. So going back to my slide about the pathogenesis of CF lung disease, so what if we could now target this? So instead of dealing with all the downstream problems, what if we could make the chloride channel work? That would be the better way to go about this, is to fix the problem so that we don't have to deal with the downstream effects. I'm going to spend a couple minutes talking about the different genetic mutations that cause CF, and then I will talk about them in context of the drugs that we have available now to treat CF. So bear with me with this little science lesson for a second. So normally, we're talking about the chloride channel that was sitting in the epithelial cell surface. So how does it get there? There are probably 2,500 to 3,000, if not more, mutations in that chromosome 7, that region that codes for the chloride channel, that can cause CF. The end result is the chloride channel doesn't work, but there are many ways to get a chloride channel that doesn't work. Those mutations have been grouped into 5 categories, depending on how their chloride channel doesn't work. So normally, within your epithelial cell, you have the DNA that makes the chloride channel. It gets processed, folded, etc., outside of that nucleus. It is transported to the epithelial cell surface, where it opens and closes, and chloride can move. That's normal. That's what should happen. In the 5 classes of mutations, each mutation works a little bit differently. So in class 1, the protein isn't even read. There is a stop mutation that stops the protein from being translated. So the chloride channel is never even made. It is not in the cell. It never gets there. It's never made. That's a class 1 mutation. Class 2 mutations, which is the delta F508, the most common, falls into class 2. The chloride channel is made, but during the processing transport step, it doesn't get done correctly. And so the protein is actually degraded, and it never makes it. It is not sitting on the surface of the cell. It never makes it there. That's the most common, the delta F508. Class 3, it's made, it's processed correctly, it gets to the surface, but it doesn't work. So it's there, but it doesn't open. So this class of mutation makes the protein, and it gets to where it needs to go. For whatever reason, it just doesn't open. These 3 are thought to be and known to be the severe mutations. So class 1, 2, and 3 are the severe mutations that result in our typical pancreatic insufficiency. Our pancreas doesn't work. We get bad lung disease. Those are the 3 classes of mutations that make that happen. In class 4, protein is made, processed correctly, gets to the cell surface, but maybe it doesn't open exactly as it should. So maybe 10%, 20%, 30%, hard to know. But some of these patients have variable function in their chloride channel. And here, it's made, it's processed, it gets there, but there just aren't physically enough of the chloride channels on the epithelial cell surface. So these 2 classes, you have some chloride function. It's not a ton, but in most patients, it's enough. So their pancreas works. They don't take enzymes, and they typically have more milder lung disease because they have some chloride function. So these are the very broad classes that these mutations fall into. So why is that important? It's important because drugs are now targeting the different mutations and trying to fix that chloride channel defect. So the first one is called Ivacaftor. The generic name is Kalydeco. And it was named because CF patients that were on this medicine said their world opened up to them, and it was like looking through a kaleidoscope. It was an entirely different world when they were on this medication. So this medicine is now FDA approved for people with CF over 2 years of age that have at least one copy of 10 very specific CFTR mutations. G551D is the most common, and these are class 3 mutations, and I'll explain why that's important in a second. So this is an oral medicine. It's either a pill or granules they take twice a day, every day, and it's known as a potentiator. So it's a potentiator of that CFTR chloride channel. So what it does, this is the class 3. Remember, the chloride channel is made, processed, and gets there. It just doesn't open. So what this potentiator does is it finds the chloride channel on the surface of the cell, it attaches itself to it, and it makes it open. So it actually physically makes the chloride channel work, but it has to be there. So people that have delta F508, the drug does not work in because the chloride channel isn't there. So here's a video. Can you bring the lights down one more time? So here's your existing chloride channel in the epithelial membrane. Here are your chloride ions not getting through. Here comes your potentiator, attaches to it, and now it opens it up and it makes it function. So it's pretty amazing how a medication like this works because it really does restore chloride channel function. Thank you. So what does this medicine do? It makes a sweat test normal. So normally, you and I probably have a sweat chloride concentration of 10 or 15. People with severe CF are typically over 100. So it brings these sweat tests down into the close to normal range. It improves lung function by about 15% in a 4-week period of time. It improves weight by about 3 kilograms, and it decreases the number of exacerbations, the number of time patients get sick within a year. Graphs and figures can be hard to understand in a talk, so I'm just going to show you one because I think this one is pretty remarkable. So this is one of the figures depicting what happens to lung function in people who got Ivacaftor versus people on placebo. So here is day 15 all the way out to week 48, and this is the change in FEV1. So here is the administration of the drug was right here. These patients went up, immediately, and they stayed up over that 48-week period of time. And these are patients across the board. These are patients with lung function in the 30 and 40% range. People that are really sick, whose lung function has never moved or budged in years. Everybody had this bump of lung function when they started this medication, and it was sustained over a period of time. So, the problem with this is that these mutations, those 10 very specific mutations, only encompasses about 8% of people living with CF. So you have a whole 90% of the population that can't use Kalydeco or can't use Ivacaftor. Because remember, this delta F508, which is the most common, does not have a chloride channel on the cell surface. So Kalydeco will not work for that reason. So they had to do something else. So the second medication that is now FDA approved is called Orkambi. And it's a combination of Ivacaftor, which I just talked to you about, but it has a second medicine in it called Lumacaftor. So that combination in one pill is now FDA approved for people 6 and above that have 2 copies of the delta F508 mutation. And trials of this medication resulted in a smaller, but still clinically significant improvement in lung function, improvement in weight, and it cut pulmonary exacerbations by about half. So Lumacaftor is a corrector. So what this does is it rescues that chloride channel from being degraded within the cell, and it helps transport it to that epithelial cell surface, where Ivacaftor can now find it and open it. So it's the combination of those 2 things that make this drug work. It is only used in delta F508 mutations, and you have to have 2 copies. So this is about 50% of our CF population. It doesn't work. It's not enough if you just have one copy and you take this medication. You don't get enough chloride channel function to have any benefit. So it's only FDA approved for people with 2 copies. So one more video. So here's the chloride channel that has just been made. And now you're going to see it be processed, folded. So it's getting folded. Now it's going to be processed. Here comes your corrector. It's going to find it, glob onto it, bring it to the surface of the cell, where now Ivacaftor can find it, bind to it, and open it up. So you need a combination of these 2 things in order for this to work. Thank you. So this is where this medication is helpful. So in people that have 2 copies of the delta F508 mutation. Here's a similar graph from what I showed you with Kalydeco, which is the same approach of across the bottom is day 15 to week 24, change in FEV1. The y-axis is the scale is much smaller. So the improvement in lung function is just above 2%. So this is not the robust 12 to 15% bump that we saw in the other population. This is a much smaller benefit. However, the bigger thing that was seen was an improvement in the number of times that people got sick during a year. So it decreases the number of pulmonary exacerbations that people had by over 50%. So you see 2 graphs, and this is the event rates over that 48-week period of time. Here's the people that were on placebo, and this study actually used 2 different doses, which is why you see a green bar and a blue bar. But this is the reduction in the number of exacerbations, percent of exacerbation, of people that had exacerbations in the year. And this is the events leading to IV antibiotics. So these are things that patients can understand. So if I tell them, if you start this drug, your lung function is going to improve 2%, they're going to be like, so what, 2%? But if you say to them, if you are on this medication and you're normally hospitalized 4 times, it's going to be 2. You're hospitalized 2 times, it's going to be once. You're hospitalized once, you may not need to come into the hospital. And they get that. They don't have to miss school. They don't have to miss work. The disruption to their lives, they understand this. And this has really made this a very attractive medicine for that reason. But it's not a perfect drug. It has a lot of side effects, drug interactions. It's not perfect by any means. But this is what we have for now. Just recently, we've had big data sets published. One of the things about CF is they are very, very focused on research. And they follow these patients for years that started on Kalydeco, that started on Orkambi. The next 2 slides I'm going to show you really are remarkable because this is the first time, really, that we've ever been able to show a drug has impacted the rate of decline of lung function. If you remember one of the charts or graphs I showed you earlier where the decline of lung function is the same, no matter what year you were born in, you're healthier, but you're going to go down the same way. These drugs affect the slope of that line. So here's Ivacaftor. This is 3 years now of people that have been on this medication. And what they did is they compared people on Kalydeco with what they called controls. So using our CF Center national database, they selected people that were delta F508 homozygous, not on any corrector or any modulating medicines, and they looked to see what was their decline in lung function over the 3-year period of time. And they compared it to those that were taking Ivacaftor. And Ivacaftor reduced the rate of decline. The slope was less. So the people taking Ivacaftor over a 3-year period of time did not have the same decline in lung function that patients that were not on it did. And the same thing was showed for Orkambi. Over a 2-year period of time, those patients that were on Orkambi had a loss of a little over 1% in their FEV1 per year. Those that were not on Orkambi had over a 2% decline in lung function over a year. And if you're talking about a span of a lifetime, that adds up in terms of how quickly your rate of decline goes down. So these 2 medicines have been really a revolutionary advance for taking care of people with CF. So to summarize, Ivacaftor, Kalydeco is useful in about 10-ish% of the CF population, and it's a good drug. It doesn't have a lot of side effects. It's pretty easy to take. and it has a very robust clinical response. Ivacaftor, Lumacaftor, which is Orkambi, useful and more, about 50% of the population. It's a plus or minus good drug. The lung function improvements was not as robust as Kalydeco, but it decreases the number of exacerbations, which is very helpful. It interacts with a lot of other things: birth control, antifungal medications, any antidepressive, anti-anxiety medications, a lot of medicines that our kids get up as they grow up, all need to be on. So there's still 40% of the CF population without a modulator therapy, and the CF Foundation has committed to finding a treatment for everybody. So they have the resources now to really invest in trying to find what they call a CFTR modulator, so something that affects that chloride channel for everybody that has CF. And I guess the last thing that I should say, so all these studies were done on patients on all of their therapy. So they took their enzymes, they did their vests, they did their inhaled medications. So one of the questions that we commonly get is, when can I stop? If I start on Kalydeco, can I not do my vest? Can I not do my inhalers? Can I not take my antibiotics? We don't know enough to say you can stop. So for now, everybody has to do everything. These improvements were seen in the context of a CF patient taking care of themselves, doing all of their therapies, or most of their therapies, you know. So for now, we can't let people stop, which is one of the big things that they want to do. This is a very burdensome disease. These are patients that do well over an hour of therapy in the morning before they go to school or work, an hour of therapy when they get home from school, and oftentimes when they're sick, they have to do their vest and therapy 3 to 4 times a day. So this is a very time-consuming, burdensome disease. And they are waiting for the day when they can stop and not have to do this anymore. So finally, I'm going to talk briefly, spend the last couple minutes just talking about our CF program. So this is us. We are big. We have a lot of people. It takes a village to take care of all of these patients. And we have an amazing adult and pediatric team. So I know a lot of you guys have met a number of us. This is one of our most recent pictures, which now is also outdated. We have a number of new team members, but you get the idea. We are a big team of people, and we all work together to take care of these patients. So every time a patient is seen in clinic, information is gathered on every patient and entered into a national registry. Lung function, weight, height, what medicines they're on. The CF Foundation keeps track of everything on everybody. It is pretty amazing, the database that is available. We are a model for really how to take care of a chronic disease and do research over time. So every year in November, the CF Foundation compiles all of this information and gives each CF program basically a report card. And it tells you, over the past year, how has your patient population done? How high was their lung function? What was their weight? How did you compare to the other 120, 30 centers across the country? So we get this data. It's available for free. You can go on cff.org, type in Minnesota, click on the University of Minnesota, and you can see all of this data. So parents can see it, patients can see it. It's available out there. So I'm just going to share 2 slides that really kind of demonstrate, I think, kind of the excellence of care that we've been able to maintain here. So lung function is the key. The healthier the lungs, the higher your lung function, the longer you're going to live. That's kind of the bottom line. So I'll explain briefly how this graph works. So this is data that looks at the FEV1 % predicted for kids between 6 and 17 years of age. Each blue bar, it's kind of probably hard to see from the back, represents an individual center across the country. We don't know who the centers are. These are just all of the centers across the country. The red bar is us. When you're looking at lung function, you want to be as high as possible. So you want to be as close to the left in this graph as you can get. So our red bar shows us that all of our kids, 6 to 17 years of age, have an FEV1 above 100%. So we are at 100.4% for our kids. That puts us well in the top 10 in terms of centers across the country for how well our kids do. And if you want to look specifically at that adolescent age range where kids tend to fall off, they don't tend to do their medications or their therapies, This is same thing, median FEV1% predicted. Now we're looking at 13 to 17, so that kind of problem years when kids don't tend to do what you're asking them to do. And again, our lung function is 98.1%, so close to 100%. So even during that time period, we still do a great job in taking care of our kids. The last thing I'm going to talk about is patient-reported outcomes or patient feedback. So again, the CF Foundation wants all of us, our CF programs, to be as excellent as we can. And in order to do that, we need to listen to and hear patient and family feedback. So they started this project a little over a year ago called the CF Patient and Family Experience of Care Survey. So patients and or family members are contacted after a clinic visit by an independent company, and they're given a survey. And they're asked a bunch of questions about their clinic visit. Data is compiled from one patient or family twice a year. And then we, again, get a report card from them about how well we're doing. And this is from the patient and the family perspective. So this is directly from them. I picked out a couple of select slides that I thought were most important that really, I think, again, show kind of how our team works and what's important to us when we take care of our patients. So the question was, how often did you feel treated with courtesy and respect by your team? This was almost 100 people that have responded, and this is about a year's worth of data. 92% felt they were treated with courtesy and respect. 8 said yes, somewhat, not sure what that means, but not one person said no. So of all the people we've seen in the past year, all of us have good days and bad days. Not one person felt disrespected by anybody in our team, which I think speaks volumes about the care that we receive or that we provide. This, I think, is even more important. So the question was, how often did your team explain things in a way that you could understand? We all take care of extremely complex and complicated diseases. It is very easy to fall into doctor talk and not explain to people exactly what you mean and exactly what you're asking them to do. 95% of our patients said yes, they were explained things in an understandable way. 5% said yes, somewhat, but again, not one person said no. Of all the people that we've seen, not one person said, I didn't understand what they were trying to say to me. And again, I think we try very hard to connect with our patients and families, and we see them often, so we have the ability to do that. But it's great to get that feedback that, yes, our patients and families actually understand. Did all of your questions get answered? By the time you left clinic, were all of your questions answered? Again, 99% of the population said either yes or yes somewhat, that their questions were answered. There was only 1% of our population that said no, that they left with questions that were not answered. And then finally, healthcare is going to be shifting and starting to shift in terms of the last couple of years towards a model of co-production. Don't cringe. My team is involved in a project specifically about co-production, and it makes some of us cringe and drink when we think about it. But the concept is that you're working directly with patients and families to have a joint team, you're making a joint decision. You're involving them in the conversation. You're asking them more about barriers, and you're trying to really have a conversation about what the treatment plan is going to be. So again, the question was, how often did you feel that you were involved in the decision-making of the team when you were in clinic? Not one person said no, that they were not. So again, not 100% of our patients feel like they are, if not definitely, somewhat involved in all the decision-making that happens. Very proud of you guys. Thank you. It's probably the first time you've seen data compiled like that. But it's wonderful to see that those are the patient outcomes directly from them on how we're doing. Okay, so in conclusion, CF lung disease still remains our biggest challenge. It's the biggest cause of morbidity and mortality in the CF population. That is what we're trying to target. If we can improve that, we're going to improve quality of life and life expectancy. 2 drugs are now FDA approved to treat the underlying chloride channel defects, Kalydeco and Orkambi. And there are many more compounds currently in clinical trials that are better and less side effects. So the goal, again, is to have every CF patient have a medicine that treats their issue. The Minnesota CF Center continues to excel at taking care of our patients and families, both in clinical outcomes, as reported by the CF Foundation, and also in patient and family reported outcomes. And honestly, that feedback is just as important, if not more important, as far as how we're doing in terms of the care we provide. So thank you guys for listening. Thank you to the team for being here, the adults and the pediatric side. This is one of my patients. He was also the guy on the front slide. He's now 8. This was his first night outdoor hockey playing goalie. So he's actually on Kalydeco. So he was part of a clinical trial here at the university. So he was started on Kalydeco when he was probably 3 or 4 years of age. He was in that initial trial. And so he is about as healthy as you can get. So thank you guys. I think we have about 10 minutes left for questions. Thank you. Hold on, microphone's coming your way.
Yeah, I know. She's running.
It's for the online people so they can hear what you're, yeah.
So those of us in rare diseases, like CF, have a universal problem that I'm going to call out right now because it's a problem for everybody, which is that these miracle drugs cost a bundle of money.
Yeah.
CF negotiated a better deal than most people because they rolled it back into their research.
Yes.
Can you talk a little bit about how we as physicians behave responsibly in the face of enormous dollars? An enormous incentive to prescribe. I mean, why wouldn't you want to prescribe? But it costs so much.
Yeah. So, I mean, I can't speak for other diseases. I can speak for us in terms of kind of our thought process. So for those of you that don't know, a year's worth of medicine, so either Kalydeco or Orkambi, costs in the neighborhood of $250,000 to $300,000. So it's not cheap. So there are issues in terms of that, in terms of the cost that is ultimately absorbed by taxpayers, society, the patients, etc. So I can tell you that for Kalydeco, so the first drug that I talked about, the benefits are impressive, and nobody had any issue putting those patients on that medication. When you're thinking about the long term with hospitalizations, quality of life, life expectancy, the potential for lung transplants, and all the care that's rolled into not being on a medication, I think that drug will pay for itself from that perspective. Orkambi is different because the lung function improvement was not the same, and it is not a great medication. So one of the slides I didn't show is that for our patient population that qualifies for Orkambi, on the pediatric side, maybe 60% are actually on it. So we're having discussions with our patients. We're looking at what are the risks and benefits. Does it make sense to have you on a drug? I can tell you, like Carly's sitting in here too, a number of our patients that have supernormal lung function, we don't start on Orkambi. We have those discussions, but it doesn't make sense fiscally to do that or clinically to do that. If your FEV1 is 130% of predicted, there's no need for you to be on a medication. And so we don't do that. So not all of our patients that qualify are automatically, I'm writing a prescription for a $300,000 a year medication. So we try to at least think through that. Your comment about what the CF Foundation did. So these drugs were discovered using high throughput screening. So CF Foundation gave millions of dollars to pharmaceutical companies to screen compound after compound after compound until they got a hit. What looked like it affected chloride channel function in cells, in a cell model. And then those were selected to move forward to animal studies, people studies, etc. Vertex is the company that makes these two drugs, and the CF Foundation invested heavily in Vertex. However, once these drugs were approved, the CF Foundation sold all of their stock that they held in Vertex and got an enormous payday. However, they have committed, and what they have done, they are using that money to find CFTR modulators for everybody else in the population. So they have been very transparent and very generous in where their money is going to. So I can't speak for other smaller diseases like that, but that's how, so that's how we've, at least the CF Foundation has combated it, but it's a big, absolutely big issue. Yeah.
So you have to make great deals. That's the bottom line. No, I'm sorry.
Terri,
terrific work. Congratulations on all you've accomplished in this. It's very impressive. I wanted to follow up on something Sue said. That the word miracle keeps sticking in my mind. And I guess I would push back a little bit on the idea that these are miracle drugs.
Sure.
And I wanted to ask you a broader question about that. I mean, the benefits are clear, I guess, and statistically significant. I have no problem with patients should be treated with these drugs, and we have to find a way to provide it for them. But I wanted to ask you about the basic science. I mean, the idea is you fix the chloride channel, that should fix the disease. But I think the data you showed and the data from the clinical trials are telling us that there's got to be something more going on here in terms of the underlying pathogenesis and the CFTR mutation. There must be some other phenotype associated with that maybe we haven't elucidated yet. I wanted to ask you sort of a broad question. What are the unsolved basic science questions here about these CFTR mutations and the disease phenotype? I think it's going to be more complex than just fixing the chloride channel.
Right. So two responses to that. So the first is that these clinical trials were started in people with established disease. So infants born with CF, with the severe form of CF, are all born with pancreatic insufficiency. So they digest their pancreas in utero. So those pancreatic ducts get blocked, and the pancreas comes out not functioning. So no drug, whether you start it at birth or beyond, is going to fix that piece. So all of these kids will have pancreatic insufficiency no matter what you do, unless we figure out a way to fix it when they're pregnant. But we haven't gotten there yet. All of these patients had established disease. They had pancreatic insufficiency, they had obstructive lung disease, and these drugs don't fix what has happened up to that point. So if someone had an FEV1 of 40% of predicted, it may go up to 50, but it's not going to fix their bronchiectasis. It's not going to take away the mucus obstruction that was already there and the damage that caused. The infections don't go away. At least we don't know that yet. So it doesn't go back and fix what has already happened. And that's a big issue. So ideally, you want to start these kids on drugs the minute they're born, that you know they have CF, so that none of these things can happen. And if we can do that, and we still get some development of lung disease, then I think that's your point is a good one. What we don't know is how much chloride channel function these drugs give you. It's not 100%. It does not take a completely dead chloride channel and make it function at 100%. So the question is, how much chloride channel function do you need to not have the severe sequelae? And that's what we're after. We don't need it to work 100% of the time. If 15% is enough, we'll take it. There's no need to go beyond that. So we may never get to the point where we're going to completely get rid of everything. But what we hope to do is attenuate it so that these people can live a normal life expectancy. So, I mean, we know that there are modifier genes. There is a lot of research that's looking at what else goes into how somebody's phenotype of CF looks. Because everyone sitting here that takes care of CF patients knows that if you put 50 people with delta F508, delta F508 mutations in a room, they all will have a different clinical course. Some get lung disease, some get liver disease, some need a G-tube, some don't grow, some are big. Why is that? There's something different, for sure. And there is work going on looking for modifier genes because there are a number of unanswered questions about why certain people with the same mutations have a very different disease.
Terry? Kathy over here.
Hey.
So, outstanding presentation, really awesome. I have two questions for you. First of all, when your kudos to your entire team, by the way, that data you presented is really, really wonderful. But a specific question, when you said the median age for survival is now around 40-ish.
Yeah.
Is that the same here? Do we have the same numbers or different?
No. So we have different numbers. So I don't know if it's been calculated recently, but the numbers that we talk about and have been told are our life expectancy is somewhere in the high 50s. Anne, is that correct? Where's Anne? Do you remember the last time that it was calculated that I heard it was right around 57, 58 years of age.
So that is really exceptional.
It is.
And you need to be telling people that.
Absolutely.
And which gets to the second part of my question, which is, so when I trained eons ago, that was that cohort at the first cohort on
Yes.
all of your slides that
Yeah.
showed where people were dying in their 20s. I mean, I
Yes.
had friends that died when I was training, and I was taking care of patients that were barely older than I was, which I never thought I was going to be doing
Right.
as a pediatrician.
Right.
But that's my question. In those days, the adult pulmonologists weren't involved in taking
Correct.
care of patients with CF because it was a pediatric disease only. And
Yes.
so do you think that your university-based sort of team approach that includes adult pulmonology along with all your fabulous pediatric team
Yeah.
and can make that transition is really part of that extended survival? And is this a model that really should be promoted and used for every patient with CF?
Yes. So yes to all of what you said. So because we were doing pediatric grand rounds, I didn't focus a lot on our adult outcomes. Our adult program is considered one of the model programs in the country. Our adult patients are some of the healthiest nationwide. And so I do think it's one of the strengths of our program is the fact that we work with our adult colleagues. We know them. We meet once a month as a group. We have really worked hard in the setting of changing logistics, moving to a new hospital away from our adult colleagues where we used to see them a lot more. We've worked hard to try to maintain that relationship because the transition piece is so important. And it's important to our families too. I mean, they grow up with us, they know all of us, and then all of a sudden they're now going to an entirely different team. So we work hard to try to let them know who those people are. And I would say that, our program is considered one of the model programs in the country, and we constantly have people coming here to see what we do and ask about our transition program, and to try to figure out how we do things here. So yes, I think we do have a model program. Hi, Mark.
Terri, thanks. That was just a terrific presentation, and you're emphasizing your multi-systematic and multidisciplinary approach, and the team aspect of this is key. And Kathy said something that made me think about Kathy's a little older than me, but not much. And we were residents together, and we were rotating on the pulmonary service, and then it was the CF service, and we worked for Dr. Warren Warwick.
Yep.
And we all thought that guy was eccentric. And as it turns out, he was a visionary.
But he was smart.
But all that weird stuff we were doing is now the mainstay of care.
Yes.
And this program, you guys are doing a wonderful thing. It's terrific. But I think we really need to acknowledge Dr. Warwick's work because
Yes.
the reason that people live here 10, 15 years longer, I think the origins are back then.
Absolutely. Thank you for mentioning that. So for you guys, so in May, Pulmonary has their second grand rounds and is devoted to Warren Warwick. And so we're having a speaker, Carlos Milas, coming back. He used to be the director here. He is going to be giving basically a keynote speech and presentation focusing on Dr. Warwick's legacy. For those of you that don't know, Dr. Warwick passed away last year. He basically is one of the pioneers of CF care. He was instrumental in developing the VEST. He was instrumental in developing the National Registry, so the database of patients. He started that back when he was here. A lot of what we do now and what is the mainstay of our care is thanks to Dr. Warwick. And he will be acknowledged in a memorial grand rounds in May. But absolutely, I think we all very much are aware of what he did in the setting of, you're a bit odd. Well, but he was. Brilliance. Brilliance, absolutely. And he revolutionized care. He was very impressive, for sure. I was lucky enough to get to know him for a short period of time when I was here. Sort of. Sue, sorry, Bill.
I'd like to invite other questions
Oh, yeah.
to come forward, please, because it is 8:30.
Yeah.
Thanks, Terri.
Yeah.
That was a great presentation.
Sure.